Hey everyone, this is James Roguski, and you are about to watch a relatively lengthy interview with Dr. Sanjeev Kumar. And I encourage you to have the patience to watch the entire video. There's a big surprise at the end. I'm not going to spoil it for you, but I really think that this is something that we all need to really give some very deep thought to. If you want your government to control the relationship that you have with your chosen healthcare professional, you should be very, very concerned about what has happened to this fine doctor. Now, Dr. Sanjeev, if you could please just start out by explaining your training and how you got to do the work that you're doing. Let people know your background, and we'll start the story there. How did you get started in the profession, and how were you trained to do what you do so very, very well?
So I basically I was born in 1980 and then started med school in 1997. And then after graduating, I actually went to med school in India. And then after graduating, I went to England to do some surgical training, spent a couple of years there, and then came to the US. In the United States, I did 4 years of OBGYN residency training at the Wayne State University in Detroit, and then a year in preliminary surgery at the Mayo Clinic. And then after that, I went back to the Mayo Clinic to finish a 3-year fellowship in gynecologic oncology.
And
So,
so, when did you perform your first? I'll make it sound like somebody getting a pilot's license. When did you first solo? When did you first actually start doing the surgery that you trained for?
yeah, independent practice I started in 2013.
Okay,
So
so
from 1997 onwards, 20 till 2013 was different phases of training.
that's well over a decade of training just to get to the point where you could do the job, that you're skilled to do. What type of surgeries did you do? What type of patients did you have? And tell us more about the fine work that you've been doing after all that training.
Yeah, so a lot of the training entails cancer surgery, women's cancers. So you're talking about cancers of the ovary, uterine cancer, any pelvic cancer, cancer of the vulva, vagina, cervix. And then because you're trained so well in these surgical excisions, cancer basically doesn't recognize any of normal anatomy fields. So as you train in resecting these surgical cancers, basically then people start referring to you any complex pathology that affects the pelvis. It's like if you can remove a cancer, you can pretty much look after any complex disease, surgical disease that happens in the pelvis. So that basically then means that as gynecologic oncologists, we become master expert pelvic surgeons. And during this fellowship, I basically started taking a lot of interest in robotic surgery. So a lot of the surgery that we do can either be open or robotic. So I had natural inclination towards specializing in robotic surgery. So that's how I basically developed a niche practice in robotic pelvic surgery. And I kept building on top of that. Robotic surgery, for those of us who are less familiar with it, is happening more and more frequently in the country and around the world. And it's gradually evolving where even telesurgery is happening now, meaning you don't need to be on site, but you can operate. Robotic surgery, just to give you a short recap, was actually originally developed in by Department of Defense funding to operate either in space or to operate in the battlefield from a ship or from the mainland. That's how the initial funding came through. But then it found its application into routine day-to-day operations. So nowadays, if we look at robotic surgery, a lot of the surgeries on the uterus, on the prostate gland in men, and a lot of other common surgeries like gallbladder are done all robotic. It has changed the landscape in surgery. So in the older times, after having a surgery, the patient will be in the hospital for several days. Now they can go home the same day. It's basically outpatient. And so it has made a sea change, and it is also rapidly evolving in future as well as more and more artificial intelligence is getting connected into it.
So, this is a hard question that you're probably not prepared for, but in the decade or so since you started doing surgery, how many procedures do you think you have performed in that decade or so?
I've performed thousands and thousands of operations. Obviously, I can't give you an exact number, but it is well over probably 4,000 or more.
Now, while you've obviously been doing those procedures, you also started a clinic, gynecological clinic. Tell me about that. When did that start? You live or was in Memphis, and tell me about the history of the clinic that you have along with your surgical practice.
Yeah. So when I came to Memphis, it was part of a service contract to serve in the underserved area in Memphis. I'm originally from India, and it was a condition for me to get a green card originally that I serve for 3 years in an underserved area under this program. It's called the Conrad 30 Service Program. So I've served in the underserved community as a part of that program, and then later on achieved my green card. And then I went through this very, very small category of immigration called EB-1A. It's called the Aliens of Outstanding Ability. And I applied through that, and I was able to get my US citizenship through that category by the virtue of the outstanding work that I did in surgery, in research, as well as in patient care. And then I was employed by this large hospital group called Baptist Memorial Healthcare Corporation. I was a division director in gynecologic oncology, and I was building the division of gynecologic oncology for the corporation across 3 state lines. So I was originally based in Memphis, and then I was traveling to Arkansas, in Jonesboro, Arkansas. And then down south, I was traveling to South Haven, DeSoto, and then further along the I-55 in Oxford, Mississippi. So I was traveling a lot, seeing a lot of patients. And then basically at some point, the practice became very saturated. And I was a big proponent of robotic surgery, and I was constantly pushing the division to do more and more of robotic surgery rather than open surgery. And the corporation, there was some resistance to it. It was a lot of old school thinking. There was a lot of open surgery going on, which I was trying to, curtail. You will be surprised to know that one of the, committees at the hospital was called the Robotic Steering Committee. And, you know, the guy who was the chair of the Robotic Steering Committee was actually an open surgeon, was not a robotic surgeon. So I took it from there and developed it quite a bit. But then I started running into resistance on basically trying to invest more money into robotic surgery. That's what I was trying to push the corporation to do, but they were not having any of it. So we ended up parting ways, and I opened a private practice in the
Approximately when in time was that?
that was in 2019.
Okay, so
So I
relatively
opened
relatively recently. Um,
right.
Now, you and I have spoken and have spoken to others about a procedure, a hysteroscopy. And I'm going to apply my layman's English to it to help people understand. People may be familiar with the colonoscopy. They may be familiar with an endoscopy. Basically, you can get a camera and look into various orifices in the body. The hysteroscopy is for women who maybe are having some type of menstrual problem, some type of pain, possibly cancer. And there's devices that can be used to view inside the womb, basically inside the uterus. And oftentimes maybe a woman would come to you and tell me if I'm wrong, but if someone has an unusual period, is bleeding unusually, uh, as with any doctor who would look in the eyes, in the nose, in the mouth, or any other orifice, um, the vast majority of step number one is to see what's going on. And so if the inner lining of the uterus sheds with every woman's period, but there's some abnormality, something going on there, one of the most reasonable things to do is to take a look using the devices that are available. And so a hysteroscopy is a common diagnostic procedure as opposed to a screening procedure. And so I'm a layman. I don't know what I'm talking about. I'm trying to learn your craft. Um, Tell me if I got anything wrong and expand on the core. Someone has a problem and they come to your clinic. You weren't necessarily the person doing those diagnostics and those examinations. You had um, registered nurses, I imagine, or physician assistants. You may have been doing a lot of surgery while people in your clinic were caring for the people who were walking in. So tell me about that aspect of your practice.
So when we opened the clinic, basically I became, um, the main surgeon. And so whosoever will come to the clinic will eventually see either me or the staff. Staff, I mean, there may be a physician assistant. For those of us who are not familiar with physician assistants, basically you have a physician or a surgeon, and then underneath them you have either nurse practitioners or um, physician assistants that help them perform a lot of the lower risk work. So I will see the most complex of the patients. If they had a problem, they will call me. But mostly be focused on doing surgeries at the hospital and the more difficult patient care and or procedures within the clinic. So imagine a busy clinic with lots of mid-level providers or advanced level providers, as we call them, combined nurse practitioners and physician assistants. And then I was covering them for complex problems. So they will, eventually, you know, percolate the more complex patients to me. So we were based in Memphis. Two-thirds of the patient population is African American. Very, very high prevalence of obesity. Obesity is a main risk factor for endometrial cancer, which is the number one cancer that I treat as a gynecologic oncologist. And if you can imagine, I'm a robotic surgeon. I do most of my work with minimally invasive surgery with, very small incisions. And the way it becomes visible is that you put a telescope in the abdomen. So I'm used to seeing first and then providing treatments. So that basically translated into the gynecologic part of the care into utilizing a hysteroscopy. So hysteroscopy is basically a very, very small, tiny little telescope. So imagine this pencil and actually reduce the diameter of this pencil into half. So my favorite telescope is like the 2.9 millimeter, which will be approximately half the diameter of this pencil. And about 4 or 5 centimeter of that, like right about this length will go into the uterus or the womb. And you can take a look around and you can see if there's an abnormal growth or a fibroid or something that looks like cancer. And honestly, in some situations, you may see that the uterus looks completely normal from inside, and yet there is a problem going on. So, endometrial cancer is two types. In type 1, you may see a growth and things like that. Is a dominant type of cancer, happens mostly in obese women. But in type 2 cancers, that can be deadly, is a more dangerous type of cancer. And sometimes the lining of the uterus looks just atrophic. Atrophic means that you can't find, any abnormalities. But still, you got to take a look around because your diagnostic yield increases. So imagine, going somewhere. On one hand, you have a choice of utilizing a Google map, and on the other hand, you're just trying to go there, trying to guess. Um, and imagine having so much technology nowadays, in today's world. So the natural inclination is to try to visualize first with a small little telescope, and then provide treatment or do sampling and things like that. So that's how the use of hysteroscopy came about. It is also very important to mention that endometrial cancer is death rate is rising one of the fastest rates amongst all the cancers in women. And in communities where you have increased risk of obesity, it's rising even at a faster rate. Also, you have this cancer happening now in more and more younger women as more and more obesity is spreading to the younger age groups. And then in racial subgroups where you have increased risk of fibroids, and African American race is known to harbor more fibroids. Um, so all of these factors, they make our population to be very, very high risk. On top of that, what happened is as I was doing more and more complex surgeries, I became known as the surgeon's surgeon. So if there was a surgical disaster in the operating room, people will call me, and then they will start sending me all of their, as they call them, messed up cases. Meaning, if they were not able to handle it, they will send the patient to me. So eventually, it became that I was, treating most of the high risk patients, and as a GYN oncologist, um, it is imperative that I make sure that the patient doesn't have cancer if they have anxiety about it or if they have risk factors. So that's how we started using the hysteroscopy. And yeah, I mean, I would do the procedure, but if I was not available or if I was doing surgery, or if the patient preferred to see one of the other advanced practice providers, they would do the procedure. So it was kind of like a mixed bag in our clinic.
So one of the things that I've learned, and I'd like for you to confirm it for me, is, and I'm still surprised by this. That's why I'm asking you for confirmation. Um, in general, while there's always possibly exceptions, it seems like the procedure for a woman to have this diagnostic test is done in a very different way in a hospital than is typically done in an office setting. And so you obviously had your own practice, you had an office setting. You did the procedure in one fashion, but my understanding is that it's done differently in hospitals and is substantially, I've heard, up to 20 times more expensive if a woman were to have this done in a hospital. Can you explain how this diagnostic test would be done in a hospital and the burdens that it would place on the person and the costs to the healthcare system? Uh, and then explain how it would have been done in an office setting, not just in your office, but in any office that would do that.
Yeah, that's an excellent question. So hysteroscopy can be done in an office setting or in a hospital setting. Hospital setting includes either proper hospital or a hospital-owned surgery center. Basically, when you go in the hospital, usually the patient receives anesthesia. So these procedures in the hospital happen either under very heavy sedation or under general anesthesia. Um, Even if the patient gets very heavy sedation, like how people do colonoscopies under very heavy sedation, you have to be able to be having capability that you can intubate the patient if the patient stops breathing. In other words, hospital means either heavy sedation and or anesthesia. In the office setting, it is way more convenient. It doesn't require heavy sedation, and it's a in and out procedure. So in the hospital, naturally, you have to pay for the cost of the operating room, the booking of the operating room, the anesthesiologist, all of their structure. And when the patient is actually completely under anesthesia, they don't feel anything, meaning there's more of a chance to perforate the uterus, to cause injuries and things like that. So I personally have had instances where other surgeons would call me that, hey, I was doing a hysteroscopy and I perforated the uterus, and unfortunately there is bowel injury and things like that, because the patient doesn't feel anything, right? Patient is under anesthesia, so patient can't tell you that no, you're um, perforating the uterus or something is not right and things like that, right? Um, and then there are logistical problems about doing this procedure in the hospital. Logistical problems are like the patient has to take time off. Frequently, you will need to show up in the hospital at 5:30 a.m. early in the morning with nothing in your belly. So you'll need to stop eating overnight. You will typically need a family member to drive you because after anesthesia you cannot drive back. And it also depends on the hospital schedule. Let's say, so this is a very quick procedure. It takes about 2 to 5 minutes. Let's say you're number 5 in operating room number 10, and the case before you was supposed to be 2 hours, but is now taking 4 hours. So you're basically out of luck, right? You may have your procedure at 10 p.m. or 8 p.m. and your entire thing is messed up. Then you're going to spend time waiting inside the hospital, even most of the night. In the office setting, on the other hand, it's quick in and out. If you don't have pain, you don't have to take pain medications. If you have pain, we can give you pain medication. Sometimes we inject what is called as a cervical block, which is like local anesthetic, but a lot of the patients don't even want that. So it can be done much more quicker. And a translation of the difference between the two, it's natural to assume that in the office setting, it is way more convenient and less expensive than in the hospital. So we checked, let's say, at the websites of many hospital systems, and it is not uncommon when you inquire that, hey, I'm going to have a hysteroscopy. What is the estimate of the price? So in the hospital, you may have an estimate of the price, you know, sometimes even 19,000, 20,000 for the procedure. So it's insanely more expensive and more risky and has less of a convenience factor um, when you consider doing it in the hospital versus in the office. Now, another thing I will tell you is that this particular situation that we are dealing with right now is majority of it is dealing with the COVID times. And in COVID times, from 2019 to 2023, um, we were trying to actually avoid using hospital resources because requirement of intubation, respiratory tract was very risky. The risk of COVID spread was, obviously high. And a lot of the patients did not want to go to the hospital because They had seen people going in the hospital and then never coming out. There were a lot of COVID deaths. There was constant push to actually triage that, hey, less risky procedures, whatever you can do in the office, try to manage it in the office. And if there's absolutely something that you have to take to the office, hospital, then only you do that. So, I mean, we were in a way trying to help the community by utilizing less of the hospital resources.
And so, as an expert who is in many ways focused on this, in 2020, 2021, 2022, on a yearly basis, how many hysteroscopies do you estimate that your practice might have done?
We never actually analyzed how many we would do in a year, but we were just so busy that the number would have been in the thousands.
Okay.
Uh,
Now,
bec-
you
bec-
you invested in, I mean, this was your business, and so my understanding is that there are the scopes themselves are either one use, and I understand while they might be thrown away, they could maybe also be refurbished. Correct me if I'm wrong on that. But there are also permanent scopes that can be reused, they can be sanitized and then reused. These things are not inexpensive. And so can you distinguish between the two? I guess maybe you did a little bit of both, but it seems uh, wasteful and expensive to buy a scope to just be used once and thrown away or go back to be refurbished. And so I understand that you invested in the permanent reusable sterilizable equipment.
yeah. So in hysteroscopy, basically it's an endoscopy. Like you take a telescope. Telescope is basically, a very tiny little tube that has light on front of it, and then you're basically looking around. So that's a endoscope, right? If you do a hysteroscopy with the endoscope, it becomes a hysteroscope, right? So the hysteroscopes can be multi-use devices or they can be single-use devices. Even in single-use devices, you have components that can be used multiple times. And then you have components that cannot be used multiple times. So even in single-use device category, you have certain components that are recycled, obviously after disinfecting them and things like that. So these are the two broad categories. Now, being a surgeon myself, and being trained on multi-use devices, our natural inclination is always to use the multi-use devices because multi-use devices are a little more nimble, they're more durable, and our traditional training is based on multi-use devices. The single-use devices, on the other hand, are a newer entrant in the market, and a lot of people are frankly not even trained on them. So that's why my natural inclination was always to use multi-use devices. But we did have single-use devices as well in the clinic. Now I personally invested a lot of funds into building a program that was based on multi-use devices. Um, so much so that I had one of the largest collections of multi-use scopes in the country. And I did that, over a course of several years, based on my needs. Obviously, we are seeing very, very high risk patient population, a lot of fibroids where the uterus, sometimes uterus is large like this, sometimes small like this. Sometimes due to fibroids, the lining of the uterus is wavy instead of it being straight and short. And multi-use devices, they usually have what we call it as articulating tip. The tip can bend, and you have a little thing like a thumb handle with which we can, navigate the contours of the uterus. So there are, if all you have is single-use devices, um, they don't they don't bend, they don't articulate, They don't have an articulating tip. So in difficult cases, you are out of luck. You just can't use them.
Now,
Um,
those single-use devices are not inexpensive. Can you give me an idea of, what it would cost for a single-use device versus the, permanent equipment? And putting this all into context of, a diagnostic in a hospital could be, I think you said $19,000 just for a diagnostic. What would it cost to do something like that with, an office visit with somebody who's invested in the equipment that they don't have to keep, reusing and reusing? Tell me a little bit of the details of, your practice and how it would actually lower costs dramatically.
yeah, yeah. Um, so I'll give you an example straight out of the Medicare website, Medicare.gov. So the Medicare website, Medicare.gov, gives you estimates of how much it costs to do a hysteroscopy. And Medicare's estimate is that a hysteroscopy costs between $1,300 to $1,900 to do it in the outpatient setting. Okay. In the hospital, sometimes they will bill up to 19,000 for it.
Dr. Kumar, the hysteroscopy is really a diagnostic tool. It's not a screening test. It's not something that a person comes in every 5 years to see if they have endometrial or ovarian or I should say endometrial or cancer of the uterus. Um, it's done as a diagnostic, and legally and with insurance programs and Medicare and Medicaid and with standard of care with medical boards and such. Please explain the difference between this same procedure, right, being done, really it's a diagnostic, not a screening, and give your view of, how doctors are generally free to do that as it is needed based on the patient care.
That's exactly right. So when we talk about hysteroscopy, it's not like a pap smear, for example. Um, Pap smear, for example, has been tested in large population-based studies, and it has been found that if we screen populations with periodic pap smears, we can actually find populations that are at higher risk of cervix cancer. And largely because of that, the prevalence of cervix cancer has gone down. So there are well-known criteria in pap smear. Up till a few years ago, a pap smear was recommended every year. That even if you're not having any problems, you gotta go see the doctor for a pap smear. In hysteroscopy, there are no screening guidelines, meaning this test has not been studied as a screening tool. Therefore, the insurance doesn't have any criteria that, hey, you gotta have a hysteroscopy every year or every 6 months or every 2 weeks. And we call them national um, determinants and local determinants. Um, what it means basically is that insurance gives you no guidance as to how frequently or how infrequently you can use this service. All right. Basically, that means that insurance regulation is non-existent. Um, when there is no pre, um, approved guideline, then what a clinician does is that the clinician uses their judgment. So if you get a patient who, let's say, has abnormal bleeding or a tumor or a fibroid, things of that nature, or just a very baseline elevated anxiety that, I don't know what's going on, but I think I may have uterine cancer, right? So then you have, various tools at your disposal. You have hysteroscopy, you have ultrasound, you have your pelvic exam. You can use them in isolation, you can use them together, or you can use them, in sequence, right? A lot of that depends on your experience as an expert, what you see, what type of patient population you deal with, and frankly, how's the clinical encounter, right? Every patient is different. Um, my training is at Mayo Clinic, where big emphasis is placed on the focus on these decisions being in the patient's own choices, right? So I am basically trained that if a patient has risk factors, I'm going to give you options. And if you choose to have a hysteroscopy, I will offer that service to you. And I, use very wide guardrails that obviously if as a patient, if you're making a very wrong choice, I'm going to stop it. But if you're not making a very wrong choice, if you're making a reasonable choice, and if I'm capable of providing that service, I will provide that service to you. I call it the modern healthcare approach. A lot of my colleagues are old school in the sense that they have a very rigid mindset that, okay, I'm going to do a hysteroscopy for this, but I'm not going to do a hysteroscopy for that. I'm not like that. I'm like a big time patient advocate in the sense that if a patient has a problem, I usually try to find the best approach to deal with that problem. And the gold standard approach in my book as a GYN oncologist for any patient who has risk factors for endometrial cancer and or high anxiety or concern is a hysteroscopy. So you take a look inside the uterus, it gives you a visual idea of what is going on inside. And on that, there's no set guideline, whether you should do it every week, whether you should do it every 2 weeks. I'll mention to you a couple of very important pieces of objective data. Okay. At Mayo Clinic, we published a study. We followed people who had endometrial cancer, and we went back and looked if they had any negative endometrial biopsy. And we found that almost up to 25% of the patients actually had a negative endometrial sampling in the past, which meant that if a patient has risk factors, having a negative endometrial biopsy, although sometimes can reassure me that there's no cancer in there, but it is not 100%. So if the patient has risk factors, I still got to evaluate them carefully. With this background, we ourselves observe at our practice at Poplar Avenue Clinic that we saw cancers being diagnosed as quick as 2 weeks. So in some patients, we will have a negative endometrial biopsy result, and within 2 weeks, we would diagnose a cancer. In some patients, that period was 4 weeks. In some patients, a precancer developed. For example, we saw a patient who was in her early 20s. We performed endometrial sampling, it was negative, and within 2 weeks, she was diagnosed with a very, very severe form of precancer. So if you adopt a rigid approach that, okay, you do a hysteroscopy, endometrial sampling, everything's negative, patient is good for next 6 months to 2 years or 1 year, that approach, in our experience, based on objective data, based on our own original observations, that is not a good approach. That will harm some of our patients, and that is never okay by me.
Um, to give a very layman's view on what you just said, correct me if I'm wrong, the analogy that pops to mind is you live in Florida and you go outside and you look out over the ocean and you don't see a hurricane. So there's not going to be a hurricane for another year. You got to keep checking. And
Yeah.
if there's a risk factor, and the person is having problems, going out and, looking to see what is happening with that particular person is dependent on the person, not on some guideline.
That's an excellent analogy. Thank you for bringing it up. I'll actually build on that. Um, the probability of getting a hurricane in Florida versus the probability of getting a hurricane in Rochester, Minnesota? Which one is higher? I would
Mhm.
argue Florida is more likely to get a hurricane. Okay. Therefore, your propensity to use your binoculars to look for a hurricane that is is probably far away, but it's more likely. And let me give you another one. You're more likely to have far looking binoculars in if you live in Florida that can spot a hurricane than you're in Rochester, Minnesota. You know why? Because the baseline probability of hurricanes is higher when you live in Florida, right? So that's the exact situation with hysteroscopy, is that when the baseline risk of endometrial cancer or other illnesses affecting the uterus is higher in your patient population, you're more likely to use it. And you cannot generalize it to, other, practices here and there, because they're not similar to your patient population. For example, population of Memphis is not the same as population of Nashville. Would you agree?
Absolutely. Yeah.
The demographics are completely different. Okay. um and then multiply on top of that your personal training and experience, and you're selectively getting these patients who are high risk. For example, um, people have published me as the go-to surgeon if you have extreme obesity. For I call it pelvic bariatric surgery, obesity related surgery, but in the pelvis, not in the stomach, but in the pelvis. It is widely known in the community that I do those type of cases. So people selectively send me that. So naturally, their prevalence in my population is much higher. So when you combine all these factors, you basically start to develop an understanding of the type of practice that I ran. Every clinical encounter stands alone. Every clinical encounter has to be evaluated independently. Yes, you take into account what happened in the past. I agree with that. But you cannot dismiss a patient's complaint when the outcome is missing a cancer, when the outcome is something that can kill you, right? Now, if you're dealing with heartburn, yes, I am totally comfortable letting you go home with the heartburn, right? If I'm a heartburn doctor, I'm a cancer doctor. If I miss a cancer, the patient's dead, right? So the pre-test probability, the pre-test prevalence of an illness, um, and you know what you're dealing with on a day-to-day basis, basically informs you how you're going to treat your patients. The second example I tried to give, which is a little bit analogous, is colonoscopy. Although the colonoscopes are much longer, the procedure is much more involved. Hysteroscope, on the other hand, is much smaller and the procedure is much more quicker. But the analogy is, let's say you had blood in stool, you went to a colorectal surgeon, they did a colonoscopy, and everything was good. They didn't find anything. 2 weeks later, if the blood in stool happens again, you go back. Will you be more comfortable as a patient if they say, well, I did that 2 weeks ago, there's likely nothing going on? Or if you're like, no, man, I have this family history, two people in my family died of colon cancer. I'm just worried. I need some answers. So, as a physician, I'm the type of expert that I like to um, leave no stone unturned. So, I like to provide you with answers if I can. So I would typically tell you that, hey, these are the options. We can wait, we can do a hysteroscopy, we can do ultrasound, or we can do ultrasound and a hysteroscopy. What option would you prefer? And if you chose to have the testing done, I'll do the testing. So It flows like that. And if we get a negative sampling, that's a good thing. If we don't find anything, that's a good thing. It doesn't mean that bad things cannot happen in future. I've personally seen cases where test was negative 2 weeks before and bad things happened 2 weeks later, right? I've seen a lot of things, and that informs my decision making.
So starting in 2019, when you started your practice, and then basically through COVID for 3, 4 years, um, you built a substantial practice. I think you said at one point you had approximately 30 people working for you. Give me an overview of how large your practice got, and the fact that it was, a walk-in. It was open 6 days a week. It wasn't like you had to go to the hospital and be admitted and all that. Tell me how your practice actually operated.
Yeah. So we had a large practice in Memphis, multiple providers. Providers meaning doctors and or physician assistants and or nurse practitioners. The total employee count could be anywhere between 20 to 45, depending on what phase you were in. On an average, I would say about 30 total employees. So large practice. And we were open 6 days a week.
Mhm.
6 days a week, we are located at the main street in Poplar Avenue in Memphis. Therefore, patients walk in. Now, typically, specialist practices, they restrict access, meaning, they put hard stops that, okay, we are open this hour to this hour, and we are not going to, see you if you had this insurance or that insurance. I never had that type of restriction. I believed in providing a service, a good service. So my clinic was open 6 days a week, no questions asked. Whatever insurance you had, even if you didn't have insurance, we will not say no to you. We will do our very best to do the very best that we can do for you, irrespective of your paying status. That was how we ran the practice. And it turned out, we started in 2019 as a brand new practice, and we became very busy very quick because patients liked it. Patients liked the convenience, patients liked the service that we were providing, and we kept growing from that point on. So that's how the practice kept getting bigger and bigger. Obviously, from my standpoint of view, we were doing a good job at providing good, affordable care to our patient population. A lot of our patients were very, very happy. They wrote thank you notes, thank you cards. They were grateful for the care that we provided. They liked the convenience. And, for us, for me especially, it was, in the line of duty is that, if somebody comes in and I use my judgment, and if something is indicated, I make the offer, explain to the patient the options, and if they choose the procedure, I went ahead and performed it. I stand by the procedures that I did, and I think that I did a good job at it. No evidence of patient harm was presented at the trial, and there were numerous lives that we saved with the care that we provided. Now, interesting thing is that every 10 minutes, a new endometrial cancer gets diagnosed in America. Every 10 minutes. And the number of cases keep increasing. So basically, if you look at the data objectively, it tells you that we are not doing enough to curtail the burden of this disease, endometrial cancer, uterine cancer. It keeps increasing. It affects disproportionately the less fortunate of our society, minorities, and it's happening. And so that's all that I think is that These services are needed. People need more access to these services rather than less. And medical necessity cannot be such a nebulous concept that, let's say, if you are an expert in a different geographical area dealing with a totally different patient population, and for whatever reason, I review some of your work. And remember, whatever work of us that was reviewed by the government was not a representative section of our patient population. They identified, they cherry picked the cases that they wanted to pick. So they picked 9 cases out of more than 5,000 patients. They excluded patients who did not have hysteroscopy from this, entire investigation. Um, they excluded Medicare Part A payments and yet kept building on the narrative that, oh, this clinic is, billing or getting paid even more than the hospitals. How can you even compare that if you're excluding Medicare Part A payments? Those are the payments that typically go to the hospital. So if you're excluding them to begin with, how can you compare us with them?
Dr. Kumar, through the time that you had your practice, obviously there were audits and, many of these things were billed years ago. Um, you passed through all of the audits, all the payments were made. Now, in retrospect, they're going back and changing their mind, even though you passed with flying colors in the past. What have you to say about that?
Yeah, I mean, that's another one of those strange things is that when the service was being provided, we were on very large scale audits. And a couple of companies put us on prepayment audits, meaning they will not pay until we submitted all the notes and all of that. And some companies had us on post payment audits where they would evaluate all the services and they will only pay if they deemed the services to be necessary. Um, and one of the insurance companies, they actually sent us a thank you email saying, hey, thank you so much for doing such a good job for our patients. Um, and these are the same time period procedures, same programs. Now hiring a chart reviewer, presenting 9 out of, 5,000 patients, and then classifying this work as medically not necessary. So kind of rehashing. Um, so it's just very, very vague. Is that tomorrow if you hire a different expert, you could have totally different conclusion.
Now, this is going to be a turn of events for people watching this video. Um, your practice is no longer open. Your practice is closed, essentially because the government, meaning the federal government, the Department of Justice, uh, raided your offices, got your information, and had a issue with the difference between um, one-use devices and reusable devices. And they did not agree, even though there are no rules or regulations, with the frequency at which the hysteroscopies were done. And rather than have a consultation with you and your business, um, they brought you up on charges of a crime being committed, even though looking at your practice, forgive me, I forget the name of the um, medical review board that had audited you and looked over everything that you were doing. Explain the situation that happened and is currently now at a stage where there's a closed session, REMER session happening that you can't really talk about. Um, After all of this work that you've done to build up a business to learn surgery and practice surgery and have this practice set up for people of all economic ranges to get the care that is needed, um, those 30 to 45 people lost their jobs because the business was effectively shut down by the charges that the government brought against you. Please explain what has happened to you over the past year or two.
Yeah, it's a nightmare scenario to put it, in a short sentence. Basically, the clinic was raided on 16th of April, 2024. And they collected a bunch of devices that day. I was not at the clinic, and construction was happening. The clinic was under construction. Um, the office manager was kind of off and on during that time. They had some sort of illness going on with one of their close family members. And Basically, I was operating, as I was explaining to you, I was doing robotic surgery at the hospital. So when the clinic was raided, instruments were collected. They took a bunch of instruments, a bunch of them from trash and whatnot, and collected them, took them with them.
Dr. Kumar, I know that you weren't in the clinic when the FBI took a bunch of equipment and when they came and raided it. But to the best of your knowledge, what is it that they actually took and then used in the case against you?
So they, obviously, I was not at the clinic. They came in and they seized a bunch of devices. Initially, they labeled these devices with very vague terminology, such as probe devices or like a grasper with a scissor handle. These type of vague and non-specific nomenclatures. They didn't take every device available at the clinic. So the criteria appeared to be a little bit vague and rather confusing because they also seized a lot of multi-use devices as well, along with that. So they actually didn't know what was a single-use device and what was a multi-use device. And it became a very, very important issue because a lot of the witnesses that were being interviewed and things like that were likewise confused as well. And they told the office manager that, hey, you can resume operations starting tomorrow, as it was reported to me. So we resume operation. I'm wondering what's going on. And then later on, we learned that they had filed the same complaint to the Tennessee, Board of Licensure, Tennessee Medical Board that controls the practice of medicine in the state of Tennessee. So I don't remember what month the investigators from the Tennessee Medical Board dropped by, unannounced, completely unannounced visit, two of them, and interviewed me extensively, took pictures, made videos, things of that nature, and went away. And then I got a letter from the Tennessee Medical Board in September of 2024 that, hey, we received this complaint and we have done extensive amount of work, investigated everything, and the complaint is being dismissed. There was no evidence of wrongdoing. So after getting this letter in September, I, assumed that practice of medicine is best known to the medical board, and they dismissed the complaint, so they're happy. and we, keep going with our daily work, working hard, serving patients. Then come in February of 2025, the next year, on a Friday morning, suddenly they arrest me. And the charge that they said was, related with sexual assault, human trafficking, sexual abuse, the Travel Act charges, um, lock me in a lockup, unseal indictment, and then basically the legal proceedings start. I'm able to get out after, spending several days in federal custody. These charges are unveiled, and then there are charges, related to human trafficking. Um, and then there are charges related to mishandling of devices, device adulteration, device misbranding, and then healthcare fraud. So those charges were brought out. Obviously, as soon as I got arrested, the clinic was closed. Then there were some bond hearings that happened. And so even though the court, basically allowed us to open the clinic, I was never able to open the clinic because the environment was just so dangerous that I didn't feel comfortable opening the clinic.
One other issue that I'd like to raise, on February 28th, 2025, the FBI posted on their website, fbi.gov, uh, I guess I'd call it an article, whatever, some sort of notice, where they were seeking information from patients involved in this investigation. Now, none of this started because of any patient complaint. It was not the case that somehow a patient had a problem and called the FBI or called the DOJ or whatever. This was the FBI seeking patient information to try to, I guess, strengthen their case because they didn't get it in that manner. And the language in this case, I'll make it available in the article, that comes along with this. There's, many phrases in here that to me are just absolutely galling. It's one of the things it says is Dr. Kumar owns Popular Avenue Clinic, which is a professional association that purported to provide women's healthcare services in the state of Tennessee. I mean, come on. You're licensed to provide care for people. You've been doing it for years, and they present it out to the public as you're purporting to provide services. And so they went in and made a lot of allegations. Did anyone come forward that you know of? Did someone come in and say, "Oh, yes, I had a problem, and therefore include me in the trial"? Or do you have any way of knowing if anything came from this notice and the FBI seeking patients to come forward?
So this is, as you can read this release, it's rather inflammatory and quite accusatory. Nobody that came forward was part of the trial or anything like that. But once a website and the government propaganda goes like that, obviously you had all kinds of people coming forward, people that I had never seen before, you know, people who were seeking money, a bunch of ambulance chasers, trying to recruit patients, trying to sue, Dr. Kumar, things of that nature. So also, I mean, it is like a classic hysteria that went on. So that is actually what happened after this case was unleashed. So it was very, coordinated effort from them to discredit me and my practice. and it did have the desired impact of enraging the public. I mean, anybody will be enraged. If I was the public, I'll be enraged, reading things like that.
Women came from the tri-state area, and somehow the government's interpretation that an unnecessary diagnostic exam, doing a hysteroscopy, became rape. It wasn't that the women complained, filed charges, had any complaint against anyone in the clinic. It was it was put forth that way simply because they believed that the frequency of the hysteroscopy being done didn't meet with non-existent guidelines, but they determined, the Justice Department, that it was an unnecessary procedure, and because it's a procedure in the private parts of the woman, they charged you with rape, which was then dropped, and then there were other charges that were replaced or replaced it. Am I speaking correctly? Would you like to add anything to that?
No, you basically summarized it well, except that you know it was pretty hard to deal with that. The trauma that I went through and the entire community went through with this, what they now labeled as quote misunderstanding. Basically, a legitimate medical hysteroscopy was charged as an act of rape or sexual misconduct, or and it became human trafficking, because if the patient came to see us in the clinic and they lived in Arkansas, or they lived in Mississippi, then they were basically engaging in human trafficking um, as a victim.
They
Uh,
trafficked themselves to your clinic from out of state and got a diagnostic procedure, and somehow that was brought up on charges by the Trump Justice Department. So when the raid occurred and the FBI took away various devices from your office was actually under construction, and more importantly, there are other rules that apply. And this is something that I think many people would not be familiar with. I certainly wasn't. I think people might understand that medical waste, hazardous waste, would be treated in a specific manner, but the rules are actually such that even before being placed into a medical waste receptacle of some kind, certain used equipment, used devices have to soak in a solution to disinfect them so that they are less hazardous. You have the ability to make them less hazardous before you put them into a hazardous disposal container of some sort. And so many of the devices that were taken or were seen in the clinic were actually soaking in a solution to disinfect them. And somehow that got interpreted as, oh, well, you're going to reuse them. And if you could talk on how that situation actually went down, that would be great.
so yes, when the FBI came for search, clinic was under construction. I was not present at the clinic. I think those two are very, very important variables. And then importantly, if you again look at CDC documents, CDC guidelines on disposal of biomedical waste, it clearly states in there that before disposing of on a device that comes in contact with any blood or potentially infective material, you gotta decontaminate it before you can throw it, because you want to reduce the bioload. What is the bioload? Bioload is presence of any potential bacteria and things of that nature. So by dipping them into Sidex, a very high level disinfectant, you're basically rendering them safer for disposal so that when the disposal crew comes in and collects them, they're not exposed to any increased risk of infective disease. It's very, very important concept. It's also important to note that a lot of the junior folks may not keep themselves abreast of these type of guidelines and may not know these guidelines all the time, right?
Item number 4 in the CDC guidance says treatment of regulated medical waste. It says regulated medical wastes are treated or decontaminated to reduce the microbial load in or on the waste and to render the byproduct safe for further handling and disposal. Dr. Kumar, you had attempted to submit a document in your trial, but you were not permitted to do so, which was an email that you had, I guess, dictated and had sent to members of your staff. And I think it was on page 6 of the document that you sent me. It made it very clear that you were, going over the details about how to disinfect various devices that people in your office would use. Um, Tell me about that, and tell me about, trying to get that into evidence in your trial.
Yeah, so it's a definitive proof of what my actual instruction was to the staff. And I believe I went above and beyond in communicating with the staff. So it's a large clinic, numerous staff members. You can't rely on verbal instruction. You got to rely on written, clear instruction. And if you actually take a look at the email, um, it clearly specifies my preferences and how I want the clinic to run. And the title of the email is actually Clinic Housekeeping. So one day when I was driving, I was just thinking that how can I, provide a lasting instruction to the staff in a detailed fashion on what everybody's supposed to do and things of that nature. So as I'm driving, I get this thought and I start dictating my thoughts on the iPhone. And when I'm done, I click send. So that is the email. It's a crucial piece of document because it's right at the beginning of the clinic. It actually has all my typos. If you actually look at it, documenting that it's a original document. You know how when you're dictating things, sometimes the words are a little messed up, and that is quite apparent in this email. But it captures the essence of my instruction. And it clearly states that I prefer multi-use devices to perform hysteroscopy. And the smaller they are, the better it is. I think at some point it mentions like 2.5 millimeter diameter, which is the smallest scope we have, and it's a multi-use device. It also goes over how each device must be either sterilized or undergo high-level disinfection according to recommended protocols. And then it clearly states that, hey, after utilization, remove these devices from the room and do it elegantly. It has that very, because sometimes when you do the procedure, the patient can be a little bit baffled if the staff is, fiddling around and things like that. And the purpose of that is to make sure that, hey, make sure you practice and make sure that you clean up nicely after the procedure is done and not display that you're, kind of all over the place and things like that. So it's quite detailed, multiple page email. And not only does it go over just the hysteroscopy, you will see that it goes over the main things that I wanted staff to do. So, for example, it has instruction for, let's say, a surgery scheduler or a lead medical assistant and the office manager, things of that nature. So, I think it was crucial. And again, it was pretty shocking that we were not allowed to enter this into evidence.
Dr. Kumar, one of the most important aspects of the investigation and the trial was centered on whether or not you were properly disinfecting, cleaning, and reconditioning, or whatever the right word might be, the devices that you were able to reuse. And the government claimed that you weren't following the proper procedures, that you were confusing single-use devices and multiple-use devices. And I understand that there was an FDA expert, supposedly, use that term loosely, who it appears to me gave inaccurate information. And has subsequently, that person has left the FDA. And so if you could expand on that, you obviously know more about it than I do. What was the situation with the supposed expert um, testimony and the information that they would not allow you to submit to the jury?
Yeah, so that was a central part of the case. Instrument disinfection slash sterilization. And one of the main controversy that was explored in the case was centered around that aspect, right? So the government held a position right from the beginning of the case that the uterus is a sterile cavity and that anything that goes in the uterus has to be a sterile instrument. If you look at the science behind it, if you read uterine microbiome, you quickly learn that uterus is not a sterile cavity. And if you read the instructions for use document for the hysteroscope in question, it's called Olympus HYF XP. That's the flexible hysteroscope that is in question. If you read its instruction for use document, um, you quickly learn that numerous times throughout the document, it is mentioned that the instrument can be successfully reprocessed with either high level disinfection or sterilization, meaning the position taken by the government was misleading. And that position, to the best of my knowledge, came directly from this FDA expert. And we have filed a motion in the court to demonstrate that point. And if you read the central excerpt of that testimony, it states that, let me remind you, FDA has never cleared a hysteroscope that can be used with high level disinfection. These hysteroscopes must be sterilized. Now, that testimony, the central aspect of the testimony, undercuts the standard of care that is going on in outpatient hysteroscopy clinics across the United States of America and possibly the rest of the world as well, because it is common practice to use Cydex OPA to perform high level disinfection of these hysteroscopes and then to use them. Going a step further, the Centers of Disease Control CDC basically recommends and demonstrates in their guidelines that for semi-critical devices, you don't get any advantage of sterilizing them over high-level disinfection, which basically means that high-level disinfection is acceptable means of disinfecting the devices before using during patient procedures. And so that's where, there's a big misunderstanding in the trial between our position as well as the government's position. And that's why we feel strongly that we are on the correct side of the scientific facts in this trial. And I believe that the court was misled because of that testimony.
Let me go a little further into that now. And again, by all means, correct me if there's anything I say that's wrong. The FDA does not govern medical practice in any way, shape, or form. They deal with drugs and device approvals. And so they approved the device and all the technical information that the device providers would give doctors in order to maintain and upkeep and use the products. So the statement that the FDA quote unquote expert made ignored the fact that you followed all of the procedures that came from the manufacturer.
Correct. And if you look at our submissions, our processes were evaluated by independent experts that are national experts in hysteroscopy. In fact, we had infectious disease physician testify in the case, Dr. Ramavi, and we had Dr. Garcia, who's a national expert on hysteroscopy. Both their testimonies were consistent that our processes met or exceeded standard of care in high-level disinfection slash sterilization. Now, the metallic instruments we were sterilizing using the autoclave. However, the flexible Olympus device you cannot sterilize because it's not composed of metal. So putting that in an autoclave will melt and severely damage the instrument. So we were using high-level disinfection for that. Now, this FDA expert surprisingly also testified that the only way to use this device is, sterilization, and the FDA has never cleared any hysteroscope that can be used with high-level disinfection. I find that to be very, very disconcerting, sitting on the other side of the table. We were able to submit the IFU, the instructions for use, but that instruction for use document was refuted by the FDA authority. In other words, she refuted the document that was cleared by her own agency, which is also surprising. What we were not allowed to introduce were the CDC guidelines that further support such a reprocessing. So the CDC guideline, there's a full-on online documentation of CDC guidelines on the disinfection and sterilization in healthcare facilities that applies across the board throughout the country to all surgical devices. And we were not able to introduce that into the trial evidence, which also is very, very perplexing.
So with the FDA testimony, the expert testimony went against the paperwork that the company provides that doctors, follow in order to abide by the guidelines from the company that the FDA approved. So it seems like, one part of the brain of the expert wasn't aware of what the other part of the FDA is doing. It approved a product that came with instructions, but they denied that those instructions are what you should do to use the product that they approved. Seems like you're damned if you do and damned if you don't.
Yeah, it appears like that, doesn't it?
Yeah.
I mean, on one hand, you have the government's own instruction for use document, the IFU, that goes through a formal vetting process through the FDA. And when the FDA clears this instruction for use document, then as a physician, you have no reason not to follow it, and you have no reason to believe that it is wrong. And then when a FDA authority comes in the court of law under oath and testifies in contrary to this document, then you're basically stuck. You're like, on one hand, the government is telling you to do something, but then on the other hand, prosecuting you for doing it what they told you you should be doing.
Now, in the question of misbranding, uh, you've informed me how the cannulas that are used, some of them for urinary use and some of them for use in examining the uterus, are indistinguishable. And
Correct.
they obviously come in a package that is labeled. And once they are taken out of the package that is labeled, pretty much nobody could distinguish. You showed me a picture of two of them, that they are essentially the same thing. And one of the accusations was that somehow you had misbranded the products essentially by taking them out of the package. And so the product, the device itself does not have a label on it. The package that it comes in, which I assume keeps it sterile and ready for use and all that sort of thing, um, they're claiming that by essentially taking the device out of the package and separating it from its label, that is misbranding the product and is now a crime. So having unpackaged, used devices in your clinic is somehow now misbranding them. That seems absolutely absurd. But can you talk to that? Because it sounds like that's, the justification that they're using for those charges.
So if you look at the photo of these particular UV cannulas, um, you cannot differentiate between a hysteroscope and a cystoscope.
And if I may interrupt, EuroV is the name of the company that manufactures them.
Correct, correct. So you can't differentiate between the two. They are physically identical as the company manufactures it. And therefore, you can't reasonably conclude that a cannula that is outside of the package is either a hysteroscope or a cystoscope. It's just physically not possible to distinguish them. And because there's no label on them, I don't understand how a device which itself doesn't have a label can be misbranded. I don't understand that.
So it seems that some of the charges are about reusing devices. And it seems that just because there is a device in the office that would have the potential to be reused, totally different and separate argument from whether or not it's been properly sterilized and so forth, and totally separate from the issue that those rules don't apply to a clinic such as yours. They absolutely did nothing to say, well, you used this device on this person on this date. It they're not saying that the device was not properly disinfected and then used on another person. They did not identify the actual crime. They did not say you used this device on this date with that person and then improperly sterilized or disinfected it and then used it again, the same device on this person. They didn't define the crime. And twice, I believe, you put in a request for a bill of particulars, give us the particulars about what it is you're claiming that was done. It would be one thing, if they had a hidden camera and, they had a patient come in and they showed what was happening, and then on another day you're doing the same thing. It's just a made up story, is what it appears to be.
So it's very, very important to know that you cannot assume use or reuse of a device just by the fact that something is laying in the clinic. I mean, you can imagine in a busy clinic, you could have devices that, you know, medical students are educating themselves with, or let's say a medical rep drops by and drops some devices there, or you have, you know, devices that are marked for disposal, but that are being disinfected. You could have numerous number of reasons why devices could be present in the clinic. You cannot assume that just because a device is present at the clinic, it was used or it is available to be used on a patient. It's a very important distinction. Hence our motion where we say that it seems to us that it has been converted as a crime of intent, meaning since no reuse on a specific patient on a specific date for a specific procedure was proven, it became a crime of intent that if the device was present in the clinic, you could find somebody guilty. And that doesn't sit right. Yeah, so that was a very, very important question for me to prepare a proper defense. Because how can you prepare a defense if you don't know the exact scenario you're dealing with? Now, the case has been falsely circulating in the media as um, proven reuse of single-use medical devices, whereas that information was never given to us. We filed a bill of particulars motion twice. It's basically which patient, which specific device, which date. And that information was never provided to us. Um, and then when the second indictment came down, we asked the same question again, because naturally any patient will naturally have the same question. Um, but it's surprising that throughout the case, throughout the trial, that was never proven. In fact, the way the case was ran was that the government doesn't need to prove um, a reuse of a device, and the government does not need to prove even the use of a device. So actually, if you look at the CDC document, the main document on page 81, I believe, it also says that the FDA guideline does not apply to unpackaged, unused single-use device. That's a very, very important distinction. So let's say a physician assistant student or a medical assistant was trying to test a device, for example, and they opened a package on the device. They put the device on the counter or decontamination bin, a bin with Sidex. Um, until you prove that this particular device has been used on a patient, until you prove that, um, the CDC documentation clearly says that the FDA regulation doesn't apply in that scenario. I'll give you a practical example of that. Let's say a medical representative, a rep, as we commonly call them, walks into your clinic and they demonstrate, let's say 20 different devices to you. And then after listening to the demonstration, everybody goes out for lunch. Those devices are still there. Now, if these devices are seized under this current case theory, you can be criminally charged because these devices can be, quote, potentially available during the course of treating a patient. So just a lot of things like that, they are very, very perplexing. Look, some clinics also have study devices or research devices. These devices are not for patient use, but you're just basically studying the device. How good is the camera? How good is the cannula? how good is the connection, things like that. Just like, you have a laptop and sometimes you are just trying to play with it to see what the different functions are. And we surgeons do the same thing. Under discharging theory, even with that, you can be held liable. That is why it is such an important thing, the patient, the specific device, the procedure to go anywhere. I don't get how. Remember, the medical board had dismissed the case, that there is no case. And then the case went forward. You read the CDC document, page number 81, it clearly says there. Um, and then on top of that, we were not allowed to admit that document into evidence. Neither were we allowed to admit the CDC biohazard waste disposal document into evidence. And so, it's a bit perplexing.
Dr. Kumar, you've guided me towards this information, so I can't take credit for it, but you helped me find it. So I'm going to read from page 81 of the guideline for disinfection and sterilization that goes all the way back to 2008 and was updated in 2024. And this is evidence that you were not permitted to submit. And it says on page 81 of this document, this FDA guidance document does not apply to healthcare settings other than acute care hospitals. And it says that the reuse of single-use medical devices continues to be an evolving area of regulations, but it clearly says that these regulations do not apply to a clinic such as yours. And you were not permitted to enter that, government document into the record as evidence on your behalf. Um, this is just the travesty of justice. That's why I think it's the Department of Injustice. The court system did not permit you to enter into evidence the guidelines, that these guidelines don't apply to your case. What do you have to say about that? My God.
Yeah, we tried hard to introduce this document into evidence. I mean, I'm not an attorney, or I don't have a practice in the court of law, but as a physician, these are the documents that I go by. Any physician who's looking for guidance will typically check, on the government websites, is that what are the government bodies that are guiding you. So if you take a look at the CDC document, that's a long document. It's a fairly lengthy document. It guides people on how to sterilize, disinfect, and use surgical devices throughout the country, across the specialties. And I relied heavily on that document in conducting my practice. On that particular page, page 81, it gives you probably a single page summary of the state of the science in the United States for the field of reuse of single-use devices. And it mentions that 20 to 30% of US hospitals reuse single-use devices, at least one type. And then it goes on to state that the FDA guidance does not apply to healthcare settings other than acute care hospitals. So obviously it is relevant to our defense. I think it is extremely relevant and crucial. Uh, but for one reason or the other, we were not allowed to introduce that into evidence. But we did try, we did fight for it, but we were not allowed to introduce it.
Now, I can understand as a juror, if you were not allowed to see that the rules do not apply, you could reach a conclusion that's wrong. Sounds to me, I'm also not a lawyer, but that would be ample reason to call a mistrial and say, hey, let's have another go at it.
I would think so. I mean, for anybody actually, it's important to see from a surgeon standpoint, it is important to understand what we usually do, um, and not looking at the CDC guideline. Nobody will do. People will always look up the CDC guideline. You hear about it on a daily basis. So that's very, very important document, and we should have been permitted to introduce it into evidence.
Rule number one in the law is jurisdiction. And if there's documentation that says this does not apply in this particular case, throw it all out. That's a game break, that's a game-changing, deal-breaking piece of information that was kept from the jury in this particular case. And so this type of thing, doctors need to know very clearly, what does apply to them and what doesn't. And in this particular case, this is just wrong beyond belief. Fast forward, they came through with another indictment. Can you explain what that was all about?
So there were three total indictments. The original one was unsealed in the end of February 2025. Then we filed few motions. The main one we filed was asking for the bill of particulars that hey, tell us which patient, which device, which date, so we could prepare a proper defense. Um, and our theory is that to prepare a defense properly, we have to know what crime allegation, what specific crime allegation we are dealing with. So we filed that motion, and then the response was increase in charges. Even with the superseding indictment, the human trafficking, rape, sexual assault charges persisted, and the device-related charges were increased. Then we renewed our motion for bill of particulars because I was still not clear
You
which
you
device.
asked you asked for them to detail what they were claiming you actually did, and rather than actually detail what they were claiming you did, they just pressed more charges, and so you had to ask for the details again.
Correct. We renewed our motion for bill of particulars. Again, the same question arises: which patient, which device, which date? And so uh, the second time, along with filing this motion, we also filed motion that a lot of the charges were very vague, and bunch of other, legalese were included in that. So finally, from February 2025 till October, in October, the sexual assault charges were dropped. Um, but then basically half of the indictment was canceled, charges were dropped. A lot of the device related charges were dropped as well. But then they came back with a vengeance. Um, they unsealed a third indictment, which was called a second superseding indictment. Our understanding was that it came from a point of view that they hired a chart reviewer, paid them on an hourly rate, and if the chart reviewer did not agree that they would perform that particular procedure, 4 years before when COVID was happening, then in their eyes, that procedure becomes, quote, medically unnecessary. And the troubling part of that is that they don't see that type of patient. They were not in our shoes dealing with the care that we provided. Um, and so, and actually, the chart review, here's the most shocking part. The chart reviewer actually does not perform office hysteroscopy in their own practice.
So the expert witness is actually not an expert.
Um, think about that for a second. So, opinion was provided to us by somebody who doesn't do office hysteroscopy. Um, and they said multiple, places that they are not aware of office hysteroscopy equipment because they don't do it in their own setting. The report was extremely flawed. They padded up, wrong procedures. They even included procedures that, according to them, were performed in 2017 when the clinic was not even open. Our clinic came into existence in 2019, and the chart reviewer put in procedures from 2017 and charged the government for it. So, a lot of things like that. And they classified several procedures as medically unnecessary, which obviously we disagree with. We had our own experts on the team. They reviewed the same data, and I would tell you that they were much more thorough in their review. For one, they did not find any procedures in 2017. Okay, I can tell you that. And then they found that, in their opinion, these procedures were medically necessary. They basically provided a lot of references on why they were medically necessary. A lot of peer-reviewed data was cited, a long report, a lot of references, and reviewed the charts carefully and came up with a completely different conclusion. Nevertheless, the case went forward. We had several experts. We had several nationally recognized experts testifying on behalf of defense. And our clinical expert, Dr. Garcia, submitted a report that our device use, uh, our practices related to device sterilization and high level disinfection, they either met standard of care or exceeded them on their independent evaluation. Um, and remember, the case had already been dismissed by the medical board. But we went through a trial, and then we were handed over a mixed verdict. And now post-trial proceedings are going on that remain under seal.
There's actually at least a couple of questions that I want to end up and ask you here. One is I won't ask you because I know it's sealed and you're not allowed to talk about it. But you mentioned that there's a sealed hearing, a REMER hearing, and I will just leave it to the audience to do a search for REMER hearing, and that's all I'm going to say about it. That is what is currently going on at the moment. I'll give an opinion, and I'm not necessarily going to ask you to give your opinion. You can if you want. But it seems to me that the government has effectively wiped out your clinic, taken away the benefit that your clinic provided to the community, to all the women in your community who now have to find some place to go that might not be a walk-in, might not take them because they don't have insurance. They might end up having to go to the hospital or wait until it's worse and go to the hospital to get the procedure that is approximately 10 times more costly. Ultimately, if people don't get care, then if they have a problem, it gets worse and becomes even more expensive. So it's almost like the DOJ has become the new Doge, using lawyers to try to cut costs when their asinine decisions and their attack on you and your clinic is ultimately going to funnel more money into the hospital system and run up the debt even higher because the care that you were providing was actually helping bring down costs by getting things early with people who would not have gotten care to begin with. Now, that's my opinion. People can have their own opinion, but I see an expert surgeon taken out of the community. That is an enormous loss that you almost can't even put a price tag on. And so, you know, thank you for helping all the people that you helped. And I just think people need to understand that the law for medical fraud, one of the things I think I told you, but when I looked over your case, I looked up the law for fraud, medical fraud, and it sent a shiver down my spine. Now, I'm not a doctor. It doesn't have any impact on me. I'm not going to be involved in any kind of, billing of Medicaid or Medicare, but it is so unbelievably vague and does not have any requirement for intent. It's not like, they have to show somebody is trying to take advantage of the system. They just interpret it however they want to interpret it. And if they say it's fraud, then it's fraud. And it sent a shiver down my spine. I don't know why any doctor, if they were to read that law, and probably in med school, they don't tell you to go read the medical fraud law. Maybe they do. But if I was the doctor and I read that law that you were charged with, I would never take another Medicare or Medicaid patient because I would be at the mercy of some Department of Justice, lawyer who, if they felt like coming after you, they can come after you. And it seems to me that that's what's happened.
Yeah, look, a lot of people have actually called me. Um, some of them actually have flat out told me that, look, we told you this before, don't take Medicare, Medicaid, it's all trouble. And they themselves don't take Medicare, Medicaid. But see, the situation is, I had never imagined
Hmm.
that I'll be in this situation. Uh, I worked too hard for, all of this to happen. Never in my, wildest dreams. Um, Not even a cell in my body that I would like to do, or engage in something fraudulent, this and that. You know, we made decisions based on our best judgment, based on what we were presented with to serve the community. I mean, we were working pretty hard, clinic open 6 days a week. And the seventh day usually, goes on to, finish charting and this and that. Average medical provider does not know all the nuances. And actually, the one thing that I learned during the trial is they said actually it doesn't matter whether you understand the statute or not. It actually doesn't matter whether you
Oh, it,
understand the
it
law.
literally says that in the statute. It doesn't matter if you know about it or not. It's
That's
for
right.
them to determine. Yeah.
Yeah, somebody mentioned a book to me, which I'm about to order. It's called Three Felonies a Day. Average American commits three felonies a day in regular course of uh, daily activities. So you and then think about it. Being charged with you know some very very horrendous things, rape, human trafficking. Even when I'm not physically in the clinic and my physician assistants are performing the procedure or providing the service to the patient, and I'm happily just doing robotic surgery at the hospital, and for those type of services, then I get charged with sexual assault, human trafficking, rape. I mean, it's unbelievable. It is unbelievable. All the while this is happening, every 10 minutes, one new endometrial cancer gets diagnosed. What are we doing about that? The disease burden for endometrial cancer keeps increasing, you know. So there's just a lot to think about this case as it moves forward. And the definition of medical necessity should not be, so gray that if one practitioner, you know, doesn't agree with another practitioner's work 5 years down the lane with absolutely zero data, zero references, zero peer-reviewed references, then, for one person it is medically necessary because they actually saw the patient and provided the service. They talked to the family, the patient. They knew what was going on at that moment in time. But then somebody, a chart reviewer comes along 5 years later and has a perfect, 2020 hindsight, um, and then, classifies that as medically unnecessary. I mean, when we were doing, um, you know, endometrial sampling, for example, we don't know when we are doing this test if the test is going to be positive, negative, or insufficient. We have zero clue. I wish I had the ability to see the future. I don't, right? We make decisions based on, what is in the present. Now, if later on the biopsy is negative, that's a great thing. And even if the biopsy is negative, if the patient has persistent symptoms or new symptoms or ongoing risk factors of endometrial cancer, they come to you, they tell you that, hey, I'm still concerned. What are you going to do? We made the decision, we offer repeat testing, and we did it. And in my judgment, that was the best for that patient that particular day in those given settings. And a lot of during that time, the pandemic was raging. Going to the hospital practically could mean that the patient could get COVID and could die of COVID, you know. So all of these things, need to be very, very carefully looked at. Um, it's a type of a case that can affect literally every specialty. I mean, think about a urologist, for example. Think about people who do vaginal ultrasound scans in radiology departments, the radiology technicians. Um, when they're doing the ultrasound, they don't know, 5 years later, guidelines change, patient symptoms change, patient forgets. And if the Medicare, Medicaid reviewer determines that, okay, these 200 procedures were not necessary, they could be charged with rape. Um, so a lot of this needs to be put into perspective. The 9 patients were included as part of healthcare fraud counts.
Okay.
Those 9 patients were cherry-picked, handpicked, um, with certain aspects of hysteroscopy. And a common thread was that these patients either had multiple hysteroscopies for one reason or the other, which are actually well documented in the medical chart, that they had well indicated medical hysteroscopies, but they had some unusual thing going on in their medical histories, like some risk factor or some difficulty obtaining a sample, some excessive high risk, or some other problems that made them higher risk, either for endometrial cancer or non-cancerous disease of the uterus. So that's how these people were identified and were put as part of a 9 count healthcare fraud. Now, these were what we understood them as medical necessity counts. That they're the main allegation the government was trying to allege was that they had medically unnecessary procedures. What is to be noted here is that Each of these patients' charts were reviewed by the defense expert, Dr. Farzan, and he concluded, and his conclusions were submitted to the court, that these patients all had documented indications that are peer-reviewed in the medical literature to have the procedure done. And none of them had a medically unnecessary procedure. And then the 10th count in the healthcare fraud was just like a blanket count from 2019 through 2024. So I think it was like multi-layered indictment. So that's how the charges were brought in. The rest of the instrument charges were, so they had 16 devices, a batch of 16 devices that they split each device into two counts. One for adulteration, one for misbranding, and that's how it became 32 counts. So you had 10 total healthcare fraud counts coming from 9 patients. Then you had 32 misbranding and adulteration counts. So we get to 42 counts, right? 32 plus 10, 42. And then they added 4 more counts of multi-use device adulteration. So that's how the indictment became 46 counts.
So, Dr. Kumar, I was obviously not at the trial, but there, coulda, shoulda, would have been a discussion of, well, what is medically necessary? What is covered by insurance or Medicare or Medicaid? What is it that the patient and the doctor have discussed that they feel is appropriate and, desired? And what are the restrictions by not necessarily law, but by Medicare policy, Medicaid policy? Um, you can't get unlimited care. People would certainly abuse that. But when you're doing something like a diagnostic that a doctor and a patient have decided needs to be done, and there are really no written rules or guidelines saying, oh, you only get one of these per year or some such thing. Please, express your opinions and observations about how that maybe wasn't properly handled in your trial, in your case.
Yeah. So if you look at the healthcare fraud counts in my case, those counts were based on medical necessity, this concept that if a medically unnecessary service was provided, then it is medical fraud. That was the premise. Now, let's pull back the curtain a little bit and let me state that there are no guidelines on how frequently a hysteroscopy should be performed, either by Medicare or by Medicaid or by any insurance company or by any national body such as American College of OBGYNs and so forth and so on. There's just zero literature on how frequently one should offer hysteroscopy or one should not offer hysteroscopy. Therefore, it becomes a discussion between the patient and their physician. And if the patient has necessary risk factors or concerns and things like that, the physician is well within the right to offer the service. So that is medically necessary, right? Now, let's extrapolate that on how the case was ran. Since there are no guidelines, there's no literature, the government hired a chart reviewer and paid them $750 per hour to produce this review. Now, I know a lot of things that a lot of people do. That's a lot of money for chart review. Okay, that's a very high rate, right? So this particular reviewer made up all kinds of things that actually don't exist in the literature. For example, they said that one can reliably rule out endometrial cancer for next 6 months to a year if a hysteroscopy and endometrial sampling is negative. I'm here to tell you there's no literature, there's zero literature that says that. Secondly, our own clinical data, our own patients, those are hard facts. We have physically seen those patients where cancer happened as early as 2 weeks. Then there's a large Mayo Clinic study which looked back and said up to one-fourth of patients with endometrial cancer actually had a negative biopsy. So, no, you cannot say that. You cannot have a duration, right? And there's no Medicare Medicaid guideline. Now, how we are entering into this fuzzy world now then is that, let's say, different insurance programs deem different services medically necessary. For example, Medicare and Medicaid typically do not cover infertility services, right? I'm just using that as an example. Now, for the patient, that service is medically necessary because obviously thousands of those services are going on around the country. Yet, for Medicare, Medicaid, it is not medically necessary, so they don't cover it. Now, does it make a crime to provide infertility services? No, it doesn't. So these are the crimes that are generated by factitious chart reviewers. My attorney put it much more eloquently than I can ever do that. He said, medical necessity should not be such a nebulous concept that it exists in the brain of a government chart reviewer only, and nowhere does it exist in medical literature. So it's like a rule that doesn't exist. It's like a mirage, It's like you can have a service that is provided. Like in my case, when these services were being provided, the patients requested them. Medicare, Medicaid actually paid for a lot of them, didn't pay a lot of them also. Um, and then few years later, then this chart reviewer comes by, and on top of that, the government builds a criminal case. In my opinion, it sets a very, very dangerous precedence.
Dr. Kumar, in the law, it seems to state very clearly, okay, that it is when a scheme to defraud the government is discovered, then that could be considered a crime, given all of the other circumstances. I think it's pretty hard to define a scheme by having, let's just say, 5,000 patients, and you cherry pick 20 of them and then whittle it down, to maybe even under 10. And I will credit your lawyer again. I think he said something that really struck home with me. If someone was to, everyone watching this, if you consider your own life and take your 5 worst days at work and be judged on those 5 worst days, 5 hardest, clients, 5 most difficult tasks. The government cherry picked some information, looked at probably some of the hardest cases, didn't really compare it to the typical, how your typical clientele might differ from nationwide or statewide or other areas where the prevalence of problems are different, and somehow decided that that was a scheme to defraud the government. If you could comment on that, I'd appreciate it.
Yeah, that's an excellent question. The Government was never able to prove a fraud scheme. Um, the attorney, when he mentions, makes an excellent point, is that you had more than 5,000 patients, of which nine were cherry picked, and the counts were built on those nine. Now, these nine were further split into various dates of service. There were several dates of service. Um, Surprisingly and curiously, patients who had the maximum number of procedures were no guilty verdict, whereas the patient where much lesser number of procedures were performed were for some reason a guilty verdict. Um, Not everybody that had a procedure was called a guilty verdict, which means there was no real scheme that could be proven. Um, s- More importantly, from a physician standpoint, it's just a practice that is happening in a clinic. You give me high risk patients, we utilized hysteroscopy service. Why is it fraud? And if it is fraud, why did the same Medicare Medicaid program that was getting benefit out of the service kept sending letters, audit is clear, audit is clean? Literally hundreds of these charts were reviewed by the same programs and said things are good. Thank you very much for doing such a good job for our patients. Why did the medical board dismiss the case? Why did literally thousands of patients kept coming back to our clinic year after year and remain satisfied with their care? That's not fraud. It's hard work for a clinic. Now, you can always find an expert, especially if you pay them real good, that can differ with another expert's opinion. See, the more specialized you become in a field, the more the disagreements. In fact, that's the very nature of the specialty. Disagreements are actually encouraged. So let's say you have an ovarian cancer patient. Today, if you send that patient to Mayo Clinic, it's more likely that they may have upfront surgery. If you send the same patient to MD Anderson Cancer Center, for example, there are more chances that they may have neoadjuvant chemotherapy. One is not right or wrong, it's just a variation in practice. Some institutions choose to perform upfront surgery and then chemotherapy. Others choose to perform, chemotherapy first, followed by surgery. It depends on each patient's variables and things like that. And, a clinician who treats a patient, when a patient comes in, has no ability to see the future, right? Nobody has a crystal ball. So when you're offering the service, you don't know whether the biopsy will be negative, biopsy will be positive, or biopsy will be insufficient. You have zero idea. You do your best, you execute all the steps, and then you take what comes along, right? Now, then to reanalyze that in a cherry-picked fashion just to build a case is where the problem happens. And that's what we meant by criminalizing the practice of medicine.
The law actually states very clearly that they do not have to show intent. And it befuddles me how someone can claim fraud. Is this accidental fraud? Well, how in the world do you define that? There's no need for the government to prove that anyone was intentionally trying to take money. They never claimed that the services were not provided. It's basically, as you said, that difference of opinion, that disagreement, has been criminalized.
That's absolutely correct. And that's where, the Three Felonies a Day book comes to mind, is that what kind of crime is it that you don't even know when you're doing it? Um, I go one step further is that for me, I was just doing my job to the best of my capability. Is that in my clinical judgment, based on my experience of actual patients, I've actually seen patients being diagnosed with cancer who had a negative endometrial biopsy hysteroscopy before. And I know what happens if you miss a cancer. I've seen people die of cancer. For me, it is not acceptable um, to do a suboptimal job for a patient, especially when you know that, okay, there's a problem, patient has risk factors, service is available. Why would you not offer it? Especially when there's absolutely zero guidance. Zero guidance means you, as a specialist, are going to use your judgment, your experience, and then provide patient focused care. Um, not in a million years I would have thought that this thing will be charged in a criminal fashion.
Apparently, using your expertise with government funded healthcare is potentially a crime.
It seems to be, especially if you look at, you read the law, um, and how complex these regulations are. Pretty much anything can be interpreted in a way to basically criminally charge somebody. So that's where we call it rather overzealous approach, especially considering the fact that the endometrial cancer keeps rising, um, and the service can actually help diagnose one early. So it's like, what type of cost are you willing to incur to save one life? Is one life important? And what is the cost that the society is willing to incur with that? All these questions. Tomorrow, if the insurance, coverage changes, will you then say that, oh, these services were necessary 3 years ago, but they are not necessary now? Um, so you can, charge people based on that. You know, that's a question that comes to mind as a potential ramification of a case like this.
You have the floor for the final word.
Yes, Don, thank you so much for the time and your platform. And please spread the word, and let's educate, people about cancer, about the rising rates of cancer. We need to save lives about, and then we need to spread the word, spread the awareness. Even if we can save one potential person from dying from cancer, that would be the greatest act we can do. So that's all I want to say. Secondly, the legal world is going in a direction that we need to evaluate, is all I'm going to say.